difficult bag valve mask is something that we can predict, and there's some different acronyms that we can use to apply. George Kovach uses BOOTS, and this would be good to keep us out of problems from sedating a patient that we don't want to sedate, or heading towards intubation with RSI or something of that nature. So just to caution us, but this also frames up when we walk in a room and we see patients with these characteristics that we can anticipate before we put a bag valve mask on their face, what's going to be difficult. So let's start off with boots. So beard and other mask seal issues. So that would be anything that's going to impede the mask sealing to the face. And a beard is one example. I've also mentioned the example of a caved in face. That would be one possible issue. The next would be obesity and obstruction. Now, obesity and obstruction is a really serious problem when it comes to bag valve mask, if I can find somewhere to put this. As far as comparing beard is an issue. Obesity is a really big issue. And dependent on the level of obesity, I'd also add in there third trimester pregnancy, history of sleep apnea. If you have those things, that is definitely concerning. I'd also add in obstruction, and if we have any swelling in the airway, angioedema, stridor, we've got a hot potato voice. We'll talk about that in a few minutes. But those would be patients that would be likely to be difficult. Older patients are more difficult to bag than younger patients. For older, toothless, we've mentioned with the beard, but if we don't have a structure to make seal, then that can be problems. And then sounds of all sorts, including snoring stridor, wheezing in the lungs, and anything of that nature. So these would be all concerning findings as we walk into the patient, into a bag valve mask situation. Now, I would like to emphasize that upper airway obstruction, that obesity, third trimester pregnancy, Ron Walls would say patients with a hot potato voice or muffled voice, difficulty swallowing in the presence of dyspnea. So if you have a raspy voice, you've all had lost your voice at some point, but you weren't short of breath. If you have difficulty swallowing and you're short of breath, or definitely if you have the presence of dyspnea. These are really key findings of upper airway obstruction. And this causes problems both with bag valve mask, but also with extraglottic and intubation. So very key findings that we should be aware of. And I would emphasize that obesity and upper airway obstruction is the most significant difficulty we run into when we turn to use a bag valve mask. So let's talk about, now that we've talked about who is likely to be difficult when we walk in the room, recognizing difficult bag valve masks. So the first thing that I would turn your attention to as far as recognize is we're not getting good chest rise and fall. And as you get more comfortable with ventilating patients and seeing positive pressure ventilation in action, you'll get used to what normal chest rise and fall is. I would echo that you should be able to auscultate lung sounds in all four quadrants, is what apices and bases. Next, I would correlate your air entry to CO2. So if CO2 is climbing, normally 35 to 45 is the range, depending on the clinical context. But for most patients, we're getting above 45, then we're getting into problems. If you have really severe problems with bag valve mask, you might have a low end tidal because you're just ventilating large airways and not getting down to alveoli. And also corresponding with that would be a low SpO2. But we'd also remember that other factors affect a low SpO2. They could be acidotic. They could have a shock state. And so the air entry and end tidal CO2 are kind of the core of what we look for. Are we getting enough air in and out of our lungs for this patient? So our tidal volume, each breath, biorespiratory, which would be our minute volume. So if we have inadequate minute volume, we're going to have poor chest rise and fall, likely decreased breath sounds on auscultation, increasing CO2, and decreasing SpO2 would all go together. Now, the answer is what to do if you run into that situation. I would say what I found in teaching paramedics is just put all the pieces together. So put OPA in, 2 NPAs, sit the patient up. Obviously, we'll have to be cautious with C-spine and putting patients into sniffing position, and then go to 2-person bag valve mask. So when you encounter difficulty, if it's a medical patient, what I'd like you to do is sit them up, no C-spine precautions, put them into sniffing position, OPA, NPAs go in, and then 2-person bag valve mask, and see if you get adequate chest rise and fall. That will rectify you'll get a appropriate chest rise and fall in the vast majority of patients with that. So I need someone else to hold the mask or to squeeze the bag, but do I get chest rise and fall with that? Can I auscultate lung sounds? Is end-tidal CO2 coming down? Then once we have adequate, and now if that wasn't working, I'd strongly consider, do we have a foreign body airway obstruction as part of this situation? Did somebody choke? Is there a piece of steak in their vocal cords? So this fixes the vast majority of difficult bag valve mask, but and has, in my career, been very, very useful. So after we've got that going, then we can kind of evaluate where was our problem. And I suggest the acronym of MULE as you walk through. And the first thing, rather than trying to work through where the problem is, I would just say sit them up, OPA, NPAs, 2-person bag valve mask, get chest rise and fall, so we're not prolonging hypoxia and hypercarbia. After that, we're going to evaluate where is the problem. Is it a mask seal problem? Is there a beard? So symptoms would be, is there a beard? Is the mask just not fitting the patient appropriately? Do we need a larger mask? Do we need a smaller mask? Can you see, is there any gaps? Is the mask folded? Is there any gaps beside the face? Can we position that mask? Is their face caved in? Do we need to put their dentures in their mouth to give us some structure to push against? So those would be all things that we could approach to. And we could consider, if those are not manageable with one clinician after kind of troubleshooting, is that an extraglottic might help us bypass that mask problem depending on the level of consciousness. Next, I'd want to turn your attention to, after M for in that MULE acronym of mask seal, is to upper airway obstruction. In upper airway obstruction, we've already talked about this. This is your obese patient, your 3rd trimester pregnancy, patient with a history of sleep apnea that has any kind of abscesses or swelling, whether angioedema and all those characteristics of hoarse voice, difficulty swallowing, dyspnea leading to this event, stridor in their history. Then those can be managed with the OPAs, NPAs. We're sitting the patient up, sniffing position. 2-person bag valve mask will help elevate that airway and position it a little bit better and pull that jaw and that tongue off the back of the throat. And an extraglottic could be helpful. Now, if you're swollen at your vocal cords, extraglottic's not going to help you in that situation. And sometimes, depending on the swelling that could be there, it could be really difficult to put an extraglottic in place. So if it's edematous, if it's from swelling, we could think about implementing medications. If this is anaphylaxis, getting IM epi and other interventions going to help mitigate that swelling that we're seeing. The other thing we should consider is this foreign body and review the history, and if concerned, go at this point, go have a look. If you're not getting good chest rise and fall and you think that it could be associated, go see if you can see if there's anything in the vocal cords by direct laryngoscopy or video laryngoscopy. The third thing that I would consider is this a lung compliance issue? As far as lung compliance, we could have a tension pneumothorax. Do we have air entry bilaterally? Do we have distended neck veins or elevated central venous pressure? Do we have hypotension? Then we consider, and we should needle decompress the affected side. Is there congestive heart failure? We might consider applying PEEP if we have an adequate blood pressure. So you could add some PEEP to help with your ventilation. We'll talk about oxygenation a little bit further. As far as asthma or anaphylaxis, things with significant bronchospasm, those medications come into play. Obviously, epi for anaphylaxis Venolin, Atrovent, these types of therapies for our patients. Remember that as patients are really bronchospastic, it becomes harder to ventilate them. You should think of an asthmatic as someone that's taken a deep breath and then trying to breathe on top of that already full lung, and they just have no space to breathe in. In this patient, it's really important that we provide adequate time between breaths. So a respiratory rate of 10 might be necessary. Remember, if you provide quick, shallow respirations, remember normal tidal volume is about 6 mils per kilogram of ideal body weight. Somebody like me, that could be 600 mils. And of that, only 150 mils of that 600, or about a quarter of it, is just in the trachea, left and right mainstem bronchi, all the way down until we reach alveolar bronchi. And there is no gas exchange there. So as we breathe shallower, less of our breath actually results in gas exchange getting down to those alveoli. So it's really important in somebody that's bronchospastic for us to go ahead and slow down our respiratory rate and be very deliberate, allowing long exhalation to provide more time for them to exhale, so we don't end up with further and further air trapping where they take that deep breath in and a little bit more and a little bit more each breath. So we don't cause more problems in a minute's time by breath stacking. So allow adequate exhalation time with those asthmatic patients is really, really, really important. The last thing that I would think about when you turn to bag valve mask is your equipment. Make sure that your bag valve mask, some bag valves, so if your MDI port isn't covered and you're getting a leak out through the side, need to get that covered. Make sure that you can create positive pressure if you stick your glove finger in the end. Make sure that your oxygen is hooked up. Those would be things we'd want to make sure that are in order, that our bag valve mask is working well, oxygen's hooked up. So when you actually get adequate chest rise and fall, then we should see a visible chest rise and fall, or get adequate tidal volume. And we should be able to hear air entry that's compatible with life. And we should see CO2 that's starting to decrease down typically, and a resulting SpO2 that's climbing. Our next video that I'm going to jump into is going to talk about difficult oxygenation. Now, obviously, there's some overlap here between if you're not ventilating, then you're not going to oxygenate well. But I would always advise you to start by focusing on get adequate minute volume, adequate tidal volume, and respiratory rate for your patient, creating air entry everywhere with an appropriate end tidal CO2, and then we can think about ways we can increase oxygenation. So check out that next video. Until then, we'll see you later.